Daily we will be discussing this. So what I am going to continue, is it really new? But I have to make it something more clinical. I am starting my talk with suppose that in our practice we are having 3 patients. They came with ejection fraction of 30%. Patient A ejection fraction. We know because of this, all the classification of heart failure based on the ejection fraction. And is it true that we rely on the ejection fraction? That's why I am going to speak like this. One patient has ejection fraction of 30%, B 30% and C 30%. Patient A telling no, I am running, walking for 400, 500 meters, I am alright. Patient B telling no sir, just 10 to 20 minutes, 10 to 20 steps, I am having shortness of breath. And patient C is telling no, I am orthopnea and having shortness of breath or the rest. But all the 3 ejection fraction is 30%. So what the difference and where is the difference? I am now focusing on the half breath. Then I will come to half breath. So ejection fraction is the one entity. But believe me, when you are looking for this heart failure, think beyond the ejection fraction. These all entity are load dependent. This depend on preload and afterload. Suppose that patient A, I have done echo at the heart rate of 70 and patient C, I have done echo on the heart rate of 120. See how difference in this feeling pressure and the coronary result. But subsequently when we are going to see that different parameter, patient A coming to their diastolic parameters, E by prime is 8, 9, 10, grade 1 diastolic dysfunction. PCWP is normal, LA index volume is the good. Nearly 30, 34 like this. But patient C having high and feeling pressure, PA pressure 60, index volume 45. And subsequently I get the strain, LA strain reduced, GLS reduced. So why we are realizing on the ejection fraction? Okay, you see the ejection fraction, but don't rely only on the ejection fraction. I am starting with this message regarding this half breath. That ejection fraction is the one entity, but this is not the all entity. Keep it remember. This is some basic pathophysiology in the half breath and with the mid-range ejection fraction. And the half breath, there is a reduced ejection fraction, LA will be dilated and we have the contractility. In half breath, usually ejection fraction is normal, although classifications say that EF more than the 50%. But usually it is more than the 60%. The problem is here, LV cavity is small. So sometimes ejection fraction is supernormal. It is 70%, but the stroke volume is reduced. LV is hypertrophy. What happens in hypertensive heart disease? LA dilated concentric hypertrophy of left ventricle. So effective cavity size is reduced. So stroke volume is less, but contractile property is maintained. So ejection fraction is maintained, but reserve of the stroke volume is reduced. So an important part of this HFpEF is problem is their diastolic property, feeling. Almost if you encounter this HFpEF patient, more than 90% of patients having either grade 2 or grade 3 diastolic dysfunction. And in the criteria for this diagnosis of HFpEF, there are 4 criteria initially built up. That patient is having some structural heart disease in form of some concentric hypertrophy of left ventricle, left atrial myopathy, and coming more important, increased LA index volume. That is almost similar to some HbA1c in the diabetic patient, high PA pressure and increased E by prime. It I will come in the slide, but I am just revising it. So these are the basic differences when you are dealing with this kind of distance and sign and symptom is almost same. No major differences. Differences going on this history. So coming to HFpEF, when you are making the syndromal diagnosis in the heart failure, the pre-adjustment fraction, this is some kind of syndrome that so many causes should be underlying this. So when you diagnose this, make it clear this you are not diagnosing one disease, you are diagnosing the syndromes. That majority of cause of HFpEF is diabetes 40%, hypertension 40%, obstructive sleep apnea, so and so and so. And you see here ultimately what changes. The problem here is a lisotropy problem with the relaxation abnormal in the HFpEF patient, and this all is the risk factor, aging, obesity, metabolic syndromes, hereditary chronic disease, CKD, that congestion, lung dysfunction, decreased LF function and development of atrial fibrillation. If you see the literature in the HFpEF patient, around 20% of patients having the atrial fibrillation, known atrial fibrillation, and that's why if you go and calculate the HFpEF score, if patient is having atrial fibrillation, there is a +3 point in the diagnosis of this and calculating the risk factors. So decreased LF function, dilution of LA, atrial fibrillation, pulmonary hypertension, pulmonary venous remodeling because of this increased LF pressure, sarcopenia and microvascular dysfunction. Microvascular dysfunction usually, I am confessing in my practice and all of us, patient coming with shortness of breath and chest pain, and we are doing ECG, echo is good or not good, doing TMT sometimes positive. Problem arises, you are sending patient for the coronary angiography, cardiac coronary is normal, all three vessels is normal. Now started from the physician, no, your heart is normal, the patient having chest pain, shortness of breath. So we are not doing the microvascular, that is more important, and if you want to see the microvascular, you will be expending around 25 to 50,000. Go for SPECT, CMR, so and so. So important the clinical diagnosis for this microvascular dysfunction rather than go for the battery of investigation. What I am thinking, and that's why I am emphasizing on this part. So this is a multifactorial origin, so you should be keeping in mind. And diagnostic algorithm, I mentioned, LVH, increase LA volume, might be some valvular, not valvular obstruction. If needed, you go for the CMR, E by A ratio, E by E prime ratio, TR velocity and PA pressure. And how should be? E by A ratio, it should be more than the 40. This is a different and medium lateral mitral valve. I am not going in this, but keep remember more than 50, 40. E by A prime TR velocity, it should be more than the 2.8 meter per second conventionally, but TR is highly hemodynamic dependent representation. Always don't rely on the one value, and PA pressure should be more than the 40. And if you want to calculate the mean pressure, PASD divided by 0.6, that will be mean pulmonary artery pressure. And sometimes diastolic stress tests are very important, non-invasive and very cheap investigation. And what the thought process behind, I am not going to conventional stress report, diastolic stress test. What the thought behind this? In the normal person, our LV and LA is moving, and movement of leaflet and this tissue Doppler, what we are having, this is normal. But when we are having disease myocardium, and when we exercise, transmitral flow velocity is increased, but E prime is decreased. So E by E ratio is increased when you are having some problem, and cheaper investigation you can carry out in your practice. And this BNP and NT-proBNP, and when patient is in the sinus rhythm, the value is different in atrial fibrillation, this value is different. But make sure one thing, NT-proBNP mentioned in the guideline, ACC, AC and everywhere. But I am telling here my seniors and everywhere is NT-proBNP only released when there is stretching of myocardium. And I am telling you that in a HFpEF there is a fibrosis. So why we are encountering for this NT-proBNP? When we are dealing with the HFpEF, maybe 1,000 of patients and having 4, 5, 6,000 like this. When the HFpEF usually this value is coming 4, 5, 6 like this. So rather than relying on the NT-proBNP, if possible you send your patient for the LA strain, and that is very useful. And you can calculate LA strain and you can make out the diagnosis. Symptom and sign, we know it very well. This is important, diabetic and hypertensive patient. when mycoid is concentric hypertrophy of blood vessels grade 2 diastolic dysfunction cellular dilation. So this is our job to treat patient like HF, not like hypertension. In every CMA, I am telling that hypertension is not a disease of just magic number. Diabetes is not just disease of this magic number of blood sugar. So you go and calculate HF score with heavy build patient, BMI more than 30, hypertensive, with atrial fibrillation. Remember it is plus 3 points. If patient is a sinus rhythm, is a 1 point, but is atrial fibrillation 3 points. Pulmonary hypertension, elderly patient, and high filling pressure E by prime 9. But E by prime 9 is not a very high level. Usually this is more than 12 and 13. This is a one score, and this is, I mean, somehow this clinical score. But if you want to calculate the echocardiographic score and major and minor criteria, you see here all these functional, septal and lateral velocity, PSD more than 35, L index volume more than the 34. LV mass index and mass rather than calculation, all these cardiologists and doing echo, if they are reporting concentric LV, they should mention relative wall thickness. That is the more important. If suppose septum is 15 mm, but LV is dilated, that is the eccentric hypertrophy, not the concentric hypertrophy. So this is mentioned to the relative wall thickness, very important. And biomarkers, this depend on this patient is a sinus rhythm or atrial fibrillation. In atrial fibrillation, this value is in the higher side. So if you go to calculate 5 or more points, that correlate with the HF. And if there is 2 to 4 points, then you go for the either diastolic spacer or some invasive monitoring. Regarding treatment, is coming to HF. I am focusing more on the HF because we know we are dealing with the HF. More and more. We know idea was just to treat the cause behind it and you will treat the disease. But right now scenario it changes and here that you don't use this and this, but you can conventionally, here he mentioned that you don't use beta blocker, but I am not convinced that in my patient is any microvascular dysfunction and heart rate of 130, shortness of breath and chest pain. Is it possible? I will not use it. I will use beta blocker. So customized treatment is the important rather than go for this blindly following this guideline. Coming to different trial with this HF, charm reserve, this was the can disorder, CHF with perendropril, eye preserve with air disorder, and top with this spironolactone. It shows that there are no superiority. So subsequently came the era of SGLT2 inhibitor and SGLT2 broad preserve. You know this causes net benefit in the primary and secondary endpoint. And same with the dapagliflozin also. This is an Indian trial from the PGI Chandigarh, and this improved the functional capacity. SEC recommendation SGLT2, MRA and the RNA. Regarding the RNA and HF, keep remember one thing. Empagliflozin is effective of all range of ejection fraction, 50, 60, 70. But RNA is only effective when you are having the EF around the 50%. This was failed. That's why paradigm HF reserve was the failed in this, and not supposed to be molecules. This is the algorithm for the treatment. Coming to some newer class of drugs and just to this is coming in the market. Maybe myosin modulator, then solvent guanylate cyclase, PI inhibitor, endocrine receptor antagonist, and some drug acting on this. And one molecule that used in this broad that is already came, that is work on the actin and myosin dot and increase this force of contraction, omecamtiv mecarbil, but that's a very expensive drug. Maybe one dose coming of 5-10 lakh like this. So, but last year I was in SSC, SCR, and they started to use this molecule. So, interleukins is an important modulator for this inflammation. So, trial is going to reduce the interleukins also with the CANTOS trial and reduce HSCRP. Some monoclonal antibody using for this, then myeloperoxidase inhibition to reduce the oxidation property. STEP program is going regarding this. An effect of semaglutide, that all diabetologists didn't know, and they are discussing the combination with this GLP and GIP. Tendronone Fidelian figure trial, and this is supposed to be came in the strongly guideline for the treatment of HF in the futures, and so many work is going on these tendronones. Relaxing is the one molecules that it is having the antioxidant and antioxidant properties. Last is if patient is having this atrial fibrillation, you go for the applied this ectopic foci. Usually you are ablating the patient with a heavy ventricular tachycardia, but with AF also this leads to ablation and do a severe stroke and hospitalization. So I think I have finished my time. So if I want to summarize in my words, heart failure diagnosis is the very easy, but don't rely on the one parameter. You open your eye for this all these systolic and diastolic parameters. As I gave example, 30 injection fraction, but on one aspect